I'd like to thank our previous speaker, Dr. Saqib, for the wonderful cover of the metabolic syndrome. It has made my work easier. I'm not going to touch about the metabolic syndrome and its cardiovascular morbidity. It's been covered in the previous session. Also, how adipose tissue is itself an endocrine organ, the adipokines, pro-inflammatory markers, everything was beautifully touched upon in the last by the last speaker. So I'm not going to touch upon anything of, and not going to talk anything on these. Dr. Saqib also spoke about the management issues, what can happen, what is available in the current scenario. So a lot of us has been covered in terms of metabolic syndrome. So I would speak less on them, and I would try to concentrate more on as a nephrologist, the kidney aspects about what comes first, whether it's the metabolic syndrome or the chronic kidney disease, or it's a bidirectional phenomena. So I'll just talk more about nephrology related aspects in terms of metabolic syndrome. Thank you. Thank you, everyone. Okay. So it's nothing but an egg and a chicken story. So what comes first, whether it's the metabolic syndrome or the chronic kidney disease, it's more like an egg and the chicken story. But what I would say is whatever comes first, it doesn't matter. But at the end of it, both of them contribute towards cardiovascular disease. And we know that for a nephrologist, one of the leading cause for death among kidney disease patients is cardiovascular morbidity. So whether it's metabolic syndrome first, or whether it's the CKD, together they contribute to an increased cardiovascular morbidity and mortality, and that's where we need to concentrate. So try to hit both of them hard to reduce the cardiovascular burden. In a nutshell, it was all explained by Dr. Saqib about the pathophysiology. I'm not going to detail on much. He explained about the central role of insulin resistance. Yes, there is an oxidative stress, inflammation, the adipose tissue expansion, which itself is an endocrine organ, altogether resulting in an endothelial dysfunction, activation of renin-angiotensin. There's an imbalance of the adipokines, and together contributing to albuminuria, hypertension, tubulointerstitial fibrosis, microvascular remodeling, podocyte injury. So the ultimate pathway for renal injury is a podocyte injury, microvascular remodeling, tubulointerstitial fibrosis. Also, it's the mitochondrial dysfunction, which is associated with, as Madam spoke in her initial introduction, how mitochondrial dysfunction, which is the workhorse for a cell, comes from the metabolic syndrome and how it contributes for its progression. So it's just a vicious cycle, each one contributing to the other's decline. Okay, let's talk about, we heard about how metabolic syndrome, cardiovascular death, cardiovascular disease in the last. I'll just touch upon how metabolic syndrome acts as a trigger for renal injury in the chronic kidney disease. Okay. Patients with 1 or 2 triads of metabolic syndrome are twice more likely to have microalbuminuria than those without the syndrome, and the likelihood rises to more than 100% in those with having more than 3 traits. We saw that the metabolic syndrome has 5 traits, and presence of even a single trait contributes to an increased risk of microalbuminuria and a reduced GFR, and this has been very well proven as early as 2 decades before. In a study including 5,800 patients with type 2 diabetes, metabolic syndrome independently predicted the new onset of chronic kidney disease. This is, again, I'm trying to tell how metabolic syndrome per se contributes to newer incidence of chronic kidney disease. This is also well known. And I'm just going in a chronological order about this. After adjustments of diabetes and hypertension, metabolic syndrome remained an independent risk factor contributing to the development of chronic kidney disease, defined as a fall in the kidney function. And this was over a prospective studies over a 9-year follow-up study. So there is definitely evidence that metabolic syndrome contributes to new onset of chronic kidney disease and its progression, both the evidence we have. There is also further evidence in different scenarios, such as patients with metabolic syndrome undergoing nephrectomy showed a higher prevalence of histological features characterizing chronic kidney disease. Patients with metabolic syndrome not diagnosed to have chronic kidney disease, but had to undergo nephrectomy for some other reason, such as a malignancy and when they did the histological examination, they had evidence for a tubulointerstitial fibrosis, suggesting there was chronic kidney disease in them. The presence of metabolic syndrome after transplantation adversely influenced allograft survival. Studies have proven. So it's not just pre-transplant dialysis dependent, it's also in the post-transplant setting. Metabolic syndrome is, as Madam said, it's more like a Trojan horse to us. Given the central role of the kidney in maintenance of bone hemostasis, metabolic syndrome may also contribute to bone mineral disorders in these subjects. So at end result is it impacts all the aspects. The metabolic syndrome impacts all the aspects of the kidney function. So even the bone health is also affected due to metabolic syndrome. So what exactly it is? So is it the metabolic syndrome which is causing chronic kidney disease, or is it the diabetes component, or is it the obesity component which is compounding? We do know that obesity causes secondary FSGS because of decrease low nephron number, and also we know that diabetes itself by hyperfiltration causes chronic kidney disease. So what exactly is it? So in the next couple of slides, I try to separate out each one of them, whether it's a metabolic syndrome, or it's the diabetes, which is a part of a metabolic syndrome, or it's obesity, which is metabolic syndrome, which is causing chronic kidney disease. So there was a meta-analysis of 11 studies in 30,000 patients, which reported that metabolic syndrome was associated with the development of chronic kidney disease stage 3, and the odds ratio was 1.55. In this meta-analysis, many of the studies specifically excluded those with diabetes. This was very important. I mean, this was a pure metabolic syndrome without a diabetes. And it itself clearly proved out that the odds ratio for developing CKD stage 3 was 1.55 in pure metabolic syndrome without diabetes. So this helped us to say that metabolism per se without diabetes contributed to new onset chronic kidney disease. Also, the NANES, that is the National Health and Nutrition Examination Survey database 3, had more than 7,000 patients, which were followed up for 2 decades, having had a normal renal function at baseline, and they had found to have an odds ratio of more than 2.6 to develop chronic kidney disease if metabolic syndrome was present. So these two clearly pointed out that metabolic syndrome per se without diabetes can contribute to new onset chronic kidney disease. Okay, so now let's look into whether obesity part of the metabolic syndrome, whether that contributes to chronic kidney disease, because we always believed obesity can cause secondary to FSGS. So this is a beautiful paper which was published last year in the American Journal of Nephrology, and which looked into it's the metabolic syndrome and not the obesity which is associated with chronic kidney disease. This was the study from Italy, and I'm sorry for the busy slide. You don't have to look through the left side of the paper. What you could look through is the right side of the logistic regression model, where you can see that in the forest plot, being obese, this is, being obese, here the reference category is not being obese, not having metabolic syndrome. So if you just look at my pointer, not being obese, but having a metabolic syndrome can result in reduced GFR, elevated urine albumin creatinine ratio. Obesity and not having metabolic syndrome did not result in decreased GFR or elevated proteinuria. However, if both of them were there, definitely the incidence of reduced GFR and proteinuria was increased compared to each of the component being alone. Now what the authors further did was which component of the metabolic syndrome would contribute to CKD. So what they realized is it's the low HDL levels and the high blood pressures. So it's the hypertension and the low HDL levels which contributed more towards development of low GFR as well as elevated urine albumin creatinine ratio. So They not only proved that the metabolic syndrome per se and not obesity contributed to CKD, they also proved the components of metabolic syndrome which could actually impact the incidence of chronic kidney disease, and hypertension and low HDL were the major risk factors. So let's see what is the pathophysiology of developing chronic kidney disease in patients with metabolic syndrome. So this is all I'm talking about the chicken story. I'll come to the egg story where I say it's the CKD which comes first and then the metabolic syndrome. Now I'm trying to tell you the chicken story where the metabolic syndrome is contributing to the development of the chronic kidney disease. I'm not going to talk too much about the pathophysiology because it's been dealt very beautifully in the last lecture. I'm just trying to tell you snippets about how metabolic syndrome causes renal parenchymal damage. It mainly induces interstitial fibrosis and tubular atrophy, and this is because of activation of RAS, and angiotensin 2, causes tubular interstitial fibrosis. There is also microvascular remodeling, and both in biopsy specimens, it has been shown there is both arterial as well as arteriolar sclerosis. And this has been proven by ultrasound evidence, called Doppler evidence, where there is elevated resistive index in interlobar arteries. So there is a stiff vessels as well as there is remodeling in the vessels. Also, accumulation of visceral adipose, as was highlighted in this thing, it itself is an endocrine organ. So accumulation of visceral adipose tissue and fat infiltration of the kidney may also induce inflammation-driven neovascularization through multiple cytokines that are enriched in adipose tissue, such as TNF-alpha and interleukin-6. So there is both neovascularization, microvascular remodeling on IFTA in renal parenchyma, secondary to metabolic syndrome, and activation of RAS. To summarize, so metabolic syndrome is nothing but a meta-afflammation, which is nothing but a meta-inflammation. And the central to this is insulin resistance, hyperinsulinemia, oxidative stress. There is an increased expression of vascular endothelial growth factor. There is increased both neovascularization from both small microvessels as well as disorganized vessels. At the end of the day, there is an increased renal blood flow, increased GFR because of the increased microvascular proliferation. And this would simulate at the early stages of diabetic nephropathy, that is the hyperfiltration. This hyperfiltration will further contribute to the decline in the GFR later. And this neovascularization have have endothelial dysfunction. They have leaky capillaries, which contribute to albuminuria. So this has been proven in both animal studies where they have done micro-CT, which clearly shows there has been increased neovascularization among patients with the metabolic syndrome. And this not just neovascularization, but there is also a CD68 positive macrophages. There is inflammatory cells in the kidney tissue secondary to fatty infiltration. So let's summarize the chicken theory. That is the potential mechanisms of chronic kidney disease in metabolic syndrome. There is an oxidative stress, there is increased pro-inflammatory cytokines, there is increased connective tissue and fibrosis secondary to angiotensin 2, transforming growth factor beta. There is increased glomerular volume, podocyte hypertrophy because of a component of secondary FSGS. There is triglyceride-free fatty acid injury. There is increased ischemia, microvascular injury, and there is hyperuricemia. All of this contributing to the development of chronic kidney disease in patients with metabolic syndrome. So once CKD stage 3 and 4 has been reached, the presence of metabolic syndrome has been associated with an hazard ratio of 1.33 to progress to end-stage kidney disease. So it just not only causes chronic kidney disease, but also causes progression of chronic kidney disease to increase the incidence of end-stage kidney disease. So that's about metabolic syndrome with the chicken story. Now let's go to the egg theory, where we say that no, it's the chronic kidney disease which starts and then which amplifies the metabolic syndrome. So what are the theories for it? The distinction between chronic kidney incidence and the progression may be arbitrary, since renal insufficiency must first progress to a point where CKD is diagnosed. What does that mean is, most of the formulas, that is the MDRD formula, most of these are valid when the GFR is less than 60. We fail to identify a lot of our patients with CKD stage 1 and CKD stage 2 because we use creatinine as a marker, and creatinine is as a poor marker of low GFR in the early stages. So if someone has a GFR of 80, creatinine may not be able to detect it early. So that's one of the main problem. So identifying CKD early has been our problem because of using creatinine or MDRD formulas or some of these formulas which fail to detect. So that's the reason it is the CKD probably which is already set in, probably stage 1, 2 CKD, which is already set in before the creatinine has gone up. So the second thing is obesity-related glomerular hyperfiltration could combine with that induced by CKD itself. CKD, there is an established CKD, stage 2, which has resulted in already glomerular hyperfiltration, and now that obesity has contributed to it, and both of them results in an accelerated glomerulosclerosis, and there is a loop which is generated. Similarly, CKD, early stages of CKD itself causes inflammation and oxidative stress. This inflammation and oxidative stress now worsens the CKD stages, and this can further worsen the hypertension and hypertriglyceridemia. So now the early stages of CKD, which goes undetected, can itself result in an hyperinflammation, hyperoxidative stress, resulting in worsening hypertension and hypertriglyceridemia. Finally, the hero of our story, the insulin resistance, this may be promoted by the undernourished state that can be caused by chronic kidney disease. In CKD stage of patients, they are usually malnourished, undernourished, and insulin resistance can be exaggerated in these states. The insulin resistance now can combine with the inflammatory milieu, and which finally would result in something called as an endoplasmic reticulum stress. And according to this theory, it is nothing but the misfolded proteins accumulated in the endoplasmic reticulums, suppressing the insulin secretion, and again, further causing phosphorylation of the insulin receptor substrate. So all together, put together, there is worsening of the diabetic component. Insulin resistance also worsens renal hemodynamics through increasing sodium retention and affecting the transport of other cations and anions. All leads to hypertension. Hypertension is exacerbated. This will further worsen the renal damage. Similarly, sympathetic activity, sympathetic nervous system is activated, again, which causes an unfavorable renal hemodynamics, proteinuria, and ischemia. Proteinuria itself, as a part of a CKD, may lead to podocyte injury, eventually lead to chronic tubulointerstitial injury, and worsen the CKD. So what the theory is trying to say that it is an undetected early stages of CKD which has set in a loop for chronic inflammation, and which now further exacerbate insulin resistance, and the metabolic syndrome starts in, which further contributes the decline in the chronic kidney disease. Now, being a nephrologist, we are more concerned about dialysis, what happens with the metabolic syndrome and dialysis. Let's start with the hemodialysis population. 50%, more than 50% of our patients who are starting on hemodialysis have metabolic syndrome. And they have a very high mortality rate, especially in the first few months after starting HD. Having metabolic syndrome in a patient starting HD, mortality is high in the first 6 months after starting HD, especially because of the cardiovascular death. So that's why we have to address metabolic syndrome much prior to starting dialysis, because once they start the dialysis, they have a very high mortality. Second, several pathophysiological mechanisms may be operational during HD that could further exacerbate metabolic syndrome. Example, insulin resistance, hyperlipidemia, hypertension, which has been carried over from the pre-dialysis stage. Further inflammation and oxidative stress can contribute to further inflammation and oxidative stress, which can result in oxidative stress is also a part of dialysis. Oxidative stress is also a part of insulin resistance hyperlipidemia. So each of them amplify the phenomena of inflammation and oxidative stress. Also, there is a loss of antioxidants and increase in leukocyte activation during dialysis, which may occur through loss of vital antioxidants through the hemodialysis and reactions to semisynthetic membranes, or both. Further, dialysis patients are also prone to infections during dialysis, And this can again cause inflammation, worsening metabolic syndrome. So hemodialysis worsens metabolic syndrome worsens contributes to increased mortality on hemodialysis. There is both logistic issues that obese patients, you can't have cannulation, you can have vascular issues. This is one other issues. Chronic volume expansions causes worsening hypertension and morbidity. And finally, insulin resistance, even in those without diabetes, may also lead to chronic malnutrition as part of overall catabolic condition. So most importantly, insulin resistance can cause a catabolic state in patients with chronic kidney disease. Let's come to the PD. This was the paper. I think Dr. Archana is also, I can see Archana as a participant. She contributed to this paper, and we can see that this was a paper which came out through SGPGI in 2013, where we saw metabolic syndrome and clinical outcomes in non-diabetic PD patients from India. What we realized is more than 50% of PD patients starting PD had metabolic syndrome. These are non-diabetic patients. More than 50% had metabolic syndrome, and patients with Sushma madam, can you just mute? Yeah, thank you.
I'm extremely sorry. Apologies.
Yeah, no. This was the paper came out from SGPGI in 2013, which clearly said that more than 50% of PD patients starting peritoneal dialysis had metabolic syndrome, and the mortality was significantly higher among PD patients with metabolic syndrome compared to those without metabolic syndrome. And this was a study in non-diabetic PD patients, which clearly said that metabolic syndrome per se can contribute to the increased mortality. Okay, sorry. Also, there is a systemic in PD. What happens is there is a systemic glucose absorption via the peritoneal membrane, leading to increased intra-abdominal fat, which is consistent with metabolic syndrome. The increased glucose load also increases serum LDL cholesterol and triglycerides, and when combined with hypertension and volume overload, can result in cardiovascular morbidity and mortality. Technique failure and subsequent conversion to hemodialysis is also a stressful state that can cause inflammation, and metabolic syndrome has been associated with an elevated white cell count and CRP independently, which is consistently independent of infection. It is associated with inflammation. That is what is the highlight. Metabolic syndrome is also associated with lower circulating adiponectin levels in PD patient, and this may contribute to increased cardiovascular disease among PD patients. So just a slide about how do we treat metabolic syndrome in the presence of CKD. To start with, there has been no obvious there is an obvious clinical need to reduce CKD morbidity and mortality, and metabolic syndrome seems to be an easily identified target. Okay. One of the probably modifiable factors is metabolic syndrome to reduce chronic kidney disease mortality. So we need to target metabolic syndrome. There have been few and far RCTs, and even if there are RCTs, they are limited by sample sizes. Renal outcomes are often not a part of the primary outcomes in these RCTs. Example, Premier was one of the RCTs. It didn't have, the primary outcome was not renal outcomes, but in the observational analysis, they showed that BP lowering in obese subjects, but again, without chronic kidney disease, showed relationship between reduction in waist circumference and urine albumin excretion rate. This was just an observation. This was not the primary outcome of this RCTs, because most of these RCTs do not have renal outcomes as their primary objectives. So in a nutshell, you need to have lifestyle modification, already explained by the previous speaker, weight loss reduction, lipid lowerings. Fibrates are a complication. It's very difficult to use, go up to the maximum doses of statins in our CKD patients. Fibrates, again, can cause severe myolysis. So you need to be cautious, and we need to sometimes monitor the CK levels in our patients. Blood pressure lowering medications, RAS is a good thing to reduce fibrosis, interstitial fibrosis, and again, controlling blood glucose. To summarize, metabolic syndrome and chronic kidney disease share a complex bidirectional relationship. Both are long-term illness. The time to onset of both metabolic syndrome and chronic kidney disease are equally difficult to determine. So it is, you don't know whether it is the egg or the chicken which is coming first, because we often detect when they are already established, but both contribute to cardiovascular disease and mortality. So that's the crux. You need to target, you need to hit them both. Patients starting dialysis with metabolic syndrome have poor outcomes on renal replacement therapy. So try to control metabolic syndrome before they progress to dialysis. Clinical intervention for metabolic syndrome in the presence of chronic kidney disease should include a combination of weight reduction, appropriate dietary modification, increased physical activity, plus targeting of individual cardiovascular disease risk factors such as dysglycemia, hypertension, dyslipidemia, while conforming to relevant national societal guidelines. Thank you.